Thank you so much, Key. I would like to also thank everybody who's been behind putting this together and those that are attending. So like Kia said, I'll probably speak from an implementer kind of perspective, somebody who's supporting governments, academic institutions, NGOs, to try and not only formulate their policy, but also get that policy to something that touches the people, which is really what you are also talking to. And obviously we can speak to issues of maternal health, which for us, we're trying to improve surgical care, is a very strong entry point for anybody to invest in healthcare or to improve surgical capacity, because it's something that the population wants, it's something that the government wants, it's something that we as policymakers and academicians and service delivery people want. So really, since 2015, when the resolution was passed, we've tried to see how we can, because you can't just move from a resolution to service delivery or a product. You need to go through the policy formulation. That's what we've been doing. And it's moving, but it's obviously slow. Everything that goes through government is kind of slow. But some governments have already got to a point where they've formulated their national health policy for improving surgical care. And when we talk surgery, obstetrics, and anesthesia, plus any other field that is related, pharmaceuticals, biomedical engineering. The challenge we've had, for example, in Zambia, we had the National Surgical Plan passed in 2017, and it ran until 2021. Obviously, the last 2 years were derailed by the COVID-19 pandemic, but the challenge we had mostly, which even government didn't really work on, and we couldn't really convince development partners or even any businesses to invest, was the fact that we were struggling with just the funding to prove the concept that a national surgical plan, when implemented, can deliver, good things, like it can really, impact health system strengthening, which everybody talks about, but nobody really unpacks it and says how we can do that. It can improve health outcomes, and overall, it can really improve the socioeconomics of the population. From our experience, we know that surgical disease is mostly physically debilitating. Of course, it also causes, mortality and other morbidity. But overall, the physical disability that results from surgical conditions is something that could easily be solved with surgical interventions, if, of course, they're delivered on time, if they are cost effective, and they are safe. And so we are struggling, and we need investors to consider, capacitating or helping us with just the pilot implementation. And when we talk pilot implementation, our goal is to improve surgical capacity at a district hospital. If not there, then maybe at the provincial or tertiary, second level hospital. Without proving or generating the evidence that, doing something like this can really work, first of all, and how it works. And then, like I said, demonstrating the impact on health system strengthening and health outcome improvement, and the socioeconomics of the people that actually go through the care, and then learning the lessons of how we do it or what we don't do and the risks involved. It's been very hard to convince anybody to invest in it. Even the governments themselves are very, very slow to invest in it. So we need catalyzing funding to help us improve that. And without that, it's very difficult to convince anybody to invest, whether they are giving you a grant, whether it's performance-based financing, whether whatever model you want to talk about. It becomes very, very hard. So for us, that's an area where we really want help, and anyone who wants to invest, of course, they can use that to test models. We can test technology, like our colleague, the first presenter, talked about investing in technology that can reduce costs. The GFF option for us was very hard, and we never really could access those funding. So that was hard. So that's one part. The other part that I probably want to highlight is the fact that since we started the whole work on improving surgical care for the people as part of universal health coverage, we've only wanted to work through the public sector. Now, the public sector or government system is very, very limited in terms of its capacity, in terms of its logistics, in terms of its bureaucracies. It's been very hard. Of late, we're really looking at how do we increase the private sector, because health cannot only be provided by governments. And even here in the low middle income countries, we clearly see that that's not working very well. For example, in Zambia, we have options for financing. We have the national health insurance. It's providing a lot of resources, but we can't provide the services. There's a lot of wait patients who are approved. The money is there. The implants are there. Everything is there, but it can't be done because it has to go mostly through the public sector, because the private sector has not really grown. Investors should start thinking of creating models of, private sector, in surgery, so that those models can actually tap into local finances that are available, and then we can grow the whole system and then serve the people. So growing the private sector in health in the low middle income countries should be something that should be considered. It's a great area that we can work in, and it can accelerate some of the things because we are not going to deliver the service through the public sector only. It will take a long time, and it takes a lot of processes that are bureaucratic, politically, poisoned, and it becomes very, very hard. Thank you.